Hello everybody. In the next few minutes we'll be using a case-based approach to illustrate the MRI-directed biopsy approach for prostate cancer diagnosis. These are my disclosures. We know that there are a number of benefits of using MRI for diagnosing patients with suspected prostate cancer. The first one is a reduced numbers of patients undergoing biopsy. The second advantage is that it reduces the diagnosis of indolent cancers. We now also know that there's a greater precision of tumor grade and volume determinations for most patients. And lastly, and you'll notice I've said this lastly, there's a decreased detection of clinically significant disease, particularly for prior biopsy negative patients, but not necessarily for biopsy naive patients. There is some controversy about this fact. But all of these advantages arise from a clinically significant prevalence of 30%, and this is important to remember. So if you had a mixed outpatient population where 3 in 10, 1/3 roughly, of men had clinically significant cancers, then a systematic biopsy would miss about 111 cancers out of 300 that were there. In other words, about 1/3 of the cancers that were there would be missed. But it would correctly diagnose 700 men as having either benign disease or insignificant cancers, but every man would need a biopsy to diagnose the absence of disease. If you used MRI for this approach, MRI would miss 84 cancers, but only 28 men would need a biopsy to confirm the absence of disease. So you can see that MRI is more likely to make a correct diagnosis using fewer biopsies in a mixed outpatient population. So what type of man benefits from an MRI scan? We can broadly divide men into men with a raised PSA and those with or without a DRE. So let's take the example of a man with a PSA of less than 10 and a DRE that's positive. So here's a typical example: a 58-year-old man, a PSA of 5.4, positive family history, and a DRE that's positive on the right side. Now you have a number of choices regarding the strategy for diagnosing this patient. Systematic biopsies is still standard of care in many places, including the USA. You could do an MRI because that's standard of care in Europe. You could use a risk calculator or other blood tests, or you could think about discharging back the patient to the GP, but I think most of us would agree this would be inappropriate. So in fact, in Europe, you would either do an MRI or you would use a risk calculator and then an MRI that follows that. So here is the imaging on this patient, and you can see that this is a PI-RADS 2 abnormality. The left lobe of the prostate is atrophic, and remember the DRE was positive on the right side. In fact, the right side is completely normal. It's the left side that's atrophic. So this is a PI-RADS 2 abnormality, likely left lobe atrophy. Now if you were to perform a systematic biopsy on this man, you see that 74 men would undergo an unnecessary biopsy and would be exposed to the side effects of biopsy. 18 men would have insignificant cancers, but 8 men with clinically insignificant cancers would also be diagnosed. In other words, to diagnose these 8 men with clinically significant cancers, all of these men would need to be biopsied. So to detect one man, 12 to 13 men would need to undergo a systematic biopsy and of course be exposed to the side effects of the systematic biopsy. Now if you omitted the systematic biopsy, then these 8 men here would be missed, and of these there are 3 men with higher grade cancers that we would also miss. So to minimize the delays for diagnosing these men, we need some sort of safety net monitoring regimen to be able to pick up these cancers as early as possible. And this is illustrated in the MRI-PATHWAY, where you can see that this man had a negative scan and went along, had an MDT review, and then had a safety net monitoring regime that was instigated, and we will discuss this towards the end of the lecture. And the guidelines agree with us. You can see the guidelines say that when an MRI is negative and clinical suspicion is low, omit a biopsy based on shared decision making. However, if the MRI is negative and the clinical suspicion is high, then you need to perform a systematic biopsy, again based on shared decision making. And that's exactly what the PI-RADS steering committee says, that if you have a PI-RADS score of 1 or 2, the recommendation is to perform systematic biopsy only if patients are at high risk. Let's take another man. You can see he's 55-year-old, he's got hematospermia, asymptomatic, his PSA is not raised, and he's got an abnormal DRE again. And again, you have the same choices. You could do a systematic biopsy, an MRI, you could use a risk calculator, or you could discharge the patient if you wanted to, but I think most of us would not recommend this. And when we did the MRI, you'll notice that there's a PI-RADS 5 lesion in the left peripheral zone with extracapsular and in fact seminal vesicle disease. So quite a lot of disease in this man with a normal PSA level. And in terms of the biopsy strategy, you could use a systematic biopsy, you could use a targeted biopsy, you could combine the two with a systematic and a targeted biopsy. You could use some other sort of biopsy method. Now, what does the EAU guidelines say regarding what one has to do with this patient? So if an MRI is positive, use combined systematic and targeted biopsies. However, in prior negative men, only perform targeted biopsies. So what are the trade-offs between using a targeted biopsy against such a large lesion in the front of the gland here and the placement of systematic cores, in this particular instance, in what appears to be normal peripheral zone? Now, if you were to perform both systematic and targeted biopsies, you would find 44 men with clinically significant cancers. If you were to omit the systematic biopsy, you would miss 5 men. In other words, to detect one of these 5 men, everybody would need to undergo a systematic and targeted biopsy. That's to say, 1 in every 20 would have a clinically significant cancer if you were to use this combined approach. Now, why is it that targeted biopsies miss cancers? Multiple studies now suggest that when we find no significant cancer after a positive MRI, it's often due to targeting errors. We also know that if you perform multiple biopsies around an MRI target, that increases the yields of clinically significant cancers without affecting the overall overdiagnosis rates. What we don't know, and what is currently under investigation, is the optimal number and the framing of the biopsies around individual lesions. And it is likely that we're going to need fewer cores for larger lesions and more cores for diffuse lesions, smaller lesions, heterogeneous lesions, or multiple lesions. So if you look at the PI-RADS committee and what they say that the recommendation in a positive MRI is to perform an MRI targeted biopsy plus a systematic biopsy, but a focal saturation is an acceptable alternative. And this patient had targeted biopsies because this is a large lesion, which showed a Gleason 9 cancer on the left-hand side. So let's conclude. What is the guidance regarding biopsy strategies in men with negative scans at low suspicion? Well, the EAU and the PI-RADS committee says omit the biopsy based on shared decision-making. However, you do need a robust safety net for men who avoid the immediate biopsy after negative scans, with everybody's responsibility being clearly defined. So a safety net could consist of discharging the patient to primary care, depending on the level of suspicion, and advising follow-up with PSAs, and then re-referring when the PSAs rise, And you can see here that the MRI use is in fact PSA prompted. However, if you have a negative scan and the patient is at high suspicion, then you do need to perform systematic biopsies, again based on shared decision making. And if the PSA is high, or the PSA velocity is high, or if you have a strong family history, then that's when you need to think about performing systematic biopsies in a negative case. What about positive scans? You can use MRI as a roadmap to guide procedures to increase the precision of biopsy. When an MRI is positive, combined systematic and targeted biopsies is the first recommendation, but focal saturation is a viable alternative. In men with prior negative biopsies and the MRI is positive, then you only really need to perform targeted biopsies. And finally, if you have a man who is positive, but you had a biopsy that was either negative or non-explanatory, and the patient is at persistent high risk, there are several options on what to do with these men. So here are my 5 golden rules for MRI use for prostate cancer diagnosis. The ones that are relevant for this lecture is the one here on the right. Do not offer immediate biopsy if the MRI is negative unless high-risk factors are present. We have to accept that not all cancers will be found immediately using the MRI approach, and we need to have robust safety nets both for negative men and for positive men who remain at persistent risk. Thank you very much for listening. Leave me some comments if you like this video. Bye-bye.